Okay, good afternoon. For those of you with whom I have not worked, my name is David Nunley. I do intensive care medicine. I also do lung transplant work. And I want to say, just for a point of clarification, the patient presented by Dr. Lederer with the hyperkalemia, who was a lung transplant, was not my patient. Okay? All right. I've been asked, well, before I get started, I always like to get an idea about my audience. This is all the residency class. Can I see a show of hands who are the incoming interns, please? Okay, how about the second years? And the third years? All right, so a large group, a lesser group, and the smallest group. Okay, good. So what I've been asked to talk to you about this afternoon is basically how to approach the ICU patient. But to accomplish this topic, I'm actually going to use a pre-made lecture by the Society of Critical Care Medicine. Now, for those of you who do not know, the Society of Critical Care Medicine is the nation's premier critical care society. It's not composed of only medical intensivists, but also surgical intensivists, anesthesia intensivists, and the sole purpose of this organization is to promote the highest quality of critical care throughout the nation. A few years ago, they created a course which was known as the Fundamentals of Critical Care Support. And this course was designed to help train physician extenders primarily, but also designed to teach residents and fellows aspects of critical care medicine. I went through a course to be a certified teacher for this, and I taught this course for many years at Ohio State University before I came to the University of Louisville. So this is what I'm going to use for the next 30 to 35 minutes to get to have this discussion with you. This is designed to be an interactive course. So we'll have a number of places where we stop along the way, and I'll ask you to interject your thoughts. Okay? So we'll get started. Let me see if I can toggle this in the correct direction. So the objectives of this course: explain the importance of early identification of patients at risk for life-threatening illnesses and the need for early intervention. Okay? Why is it important to recognize somebody who is progressing to critical illness? And how do you recognize the early signs and symptoms? And then how do you assess the early treatment of critically ill patients? You may or may not be surprised to know that numerous studies have actually noted that patients who are deteriorating, oftentimes for many hours before a MET team is called, before an intensivist is called, have been showing clear signs of deterioration. But no one has recognized and acted on those signs to try to stabilize the person before the bottom has fallen out. So that's one of the goals of this course, was to teach that. Whoops, wrong way. So why is it important to identify patients at risk? Well, if you intervene earlier, the odds are that you can do simpler interventions to stabilize a patient. Okay? You don't want to wait till they're on 100% oxygen and they need an emergent airway before you, as an intensivist or whatever your role is in the hospital, gets called to see them. You want to see them earlier because many times you can stabilize people with much simpler interventions. So by doing this, you prevent or slow the rate of deterioration, and this allows you extra time for deciding their disposition and deciding what investigations and treatments that you must employ. Now remember, this course was designed not necessarily for the patient already in the ICU, but the patient anywhere that you may see, whether in the emergency department, the outpatient clinic, on the wards, or a patient who's already in an intensive care setting. So this is designed to wherever you encounter this patient, how to approach them from the get-go. So the course is designed to do this with a problem or a clinical scenario sort of approach. So this is the case that we're going to consider for the next 30 minutes. And I'm going to have you guys to interact with me and tell me what you want to do with this. We have a 54-year-old diabetic lady who had cholelithiasis and recurrent pancreatitis, and she undergoes laparoscopic cholecystectomy. And she develops shortness of breath 3 days later while in the hospital, and you are called to evaluate her. So the first question, is this patient seriously ill? Well, I'll answer this one for you. If she wasn't, we wouldn't be talking about her, okay? You have to suspect this patient is seriously ill. What sort of things, just based on this short presentation, should heighten your awareness that there could be something significantly wrong here? I'm sorry? She's diabetic. She's post-surgical. She's not particularly young anymore. She's middle-aged. And right. She has a history of recurrent medical problems. So all of these things certainly should be red flags. So how are you going to approach this patient? What kind of information are you going to obtain? Well, however you ask your questions, however you approach the patient, basically you're trying to address these two questions. You're trying to understand their background health. Well, why is that important? Well, different patients have different levels of reserve. That is to say, when you approach a 54-year-old diabetic, they may be physiologically more like a 64 or 74-year-old person, and that's going to be that person's going to have a different level of reserve capacity. You're going to be able to have more time, potentially, with a person like that than you are, you're going to have less time with a person like that than, let's say this was a 20-year-old with the same sort of situation, okay? So you have to have an idea about what the background health of this person is, and then you have to understand the physiology with which you're dealing, okay? Cardiac, respiratory, is this person at risk for cardiovascular collapse? So you have to be thinking about how their physiology has changed and may change in the ensuing minutes to hours. When you approach this patient, is it necessary to know their diagnosis? Is it important for you to go in the room and see this person and say, this person has pneumonia, sepsis, pulmonary embolism, myocardial infarction? Do you need to know that when you walk in? No. And that's one of the points of this course, is that you don't always have to make a diagnosis right up front. We'll talk about what's called the primary survey and the secondary survey. The primary survey is when you go in, how should you approach a patient where you're going to make a quick, within minutes, assessment and value judgment, and then put action, take some sort of action. And then do a secondary survey, which is where you're more explorative and trying to find out what was the underlying cause. And it's really in this part of your approach that you're going to start thinking about a differential diagnosis. Both the primary and the secondary survey consist of these elements: a history, a physical, some sort of review of the documentation that you have available to you, ordering some investigations, and implementing some sort of treatment. So if we go back to our case, the diabetic lady who's 54, you're walked in, you're seeing this patient for the first time. What sort of history would you like to obtain? What sort of things do you want to know? And remember, you're trying to do this in minutes to decide how to intervene to stabilize this person so that they don't deteriorate any further. So what are the key things that you want to know about this lady? What would you ask? Anybody? Sorry? When did it start? Okay. Duration. All right. Was it sudden or has it been gradual? Okay. What else might you want to know? I'm sorry? Okay, that might be something I might ask in a secondary survey if I'm walking into this person, but what about something else?
Does she have any sort of COPD or something like that?
Okay, so does she have any other pertinent medical history? All right. What I would ask on this person is, how long has this been happening? Is it associated with any other symptoms? Does this person have associated chest pain? Does this person have a cough? Has this person had fever and chills? Those are the sort of things I want to get an idea about this onset of shortness of breath. So when you take this history, you want to know what the main symptoms are. We've been told this woman is short of breath, but we want to know if there's any other things that are associated with this onset of shortness of breath. Because if she's having retrosternal heavy chest discomfort, I might be thinking myocardial infarction, even though at this point I'm still not making a differential really. But that might pop into my head as opposed to she's coughing up purulent sputum, where I might think she may have more of like a lower respiratory infection. Coexisting illnesses, such as, has she had any other pertinent medical history? Is she a heart failure patient? She had 3 cabbages, so forth. Any recent medications? Now, you don't need the 25 medicines that she's been on at home. What you want to know when you're approaching a patient is, have they received anything here recently within the last 2 to 6 hours, okay, that maybe is not one of their routine medicines. So really when you, as part of the initial survey, the primary survey, you want to know any medications that have been given very recently. For example, if this person had received, let's say, a lot of beta blockers, and they're not normally on beta blockers, and they have a history of congestive heart failure, now you might be thinking, your mindset might be going more toward this person might be in heart failure and pulmonary edema. Okay? Has there been any recent trauma or manipulation of the patient? If you get called to see a patient who's short of breath 3 days post-op, and you're trying to figure out what's wrong, and the nurse happens to say, well, you know, the surgical resident was just up here 30 minutes ago, and they were trying to get a central line in, and they were having all kinds of trouble, but they had to run and go to the ER. Now what might pop to the top of your head? The person might have a pneumothorax, okay? So you want to know that has there been any recent sort of a trauma or intervention, and then not just severe hemorrhage and transfusions, but also any excessive fluid changes. They've been diuresed heavily, or they've been getting a lot of intravenous fluids. Those sort of things are what you want to know. Okay, now we're still in our primary survey. You just walked in, and you've just been given this case. You're still within the first 30 seconds. And now how do you want to focus your physical examination? What sort of things do you want to focus on immediately and only? Okay, here's vitals. What else? Lung exam. Okay, what else? Let's keep it a little simpler. All right, think of how everybody had ACLS and BCLS. All right, what's the first thing they tell you when you approach a down patient? Right, okay. Annie, are you okay? All right. The primary survey examination should be just this simple. Do they have an airway? Are they carrying on respiration? Are there signs of good circulation, and are they conscious? And this is why they teach you in ACLS to do, you know, Annie, are you okay? If somebody can open up their eyes, respond to you verbally, they probably have a good pulse. They probably have some level of awareness, and they're probably breathing, okay? So very quickly, you can get a general assessment of these things just from that. And really, as part of your initial survey, you're trying to do this within minutes. This is all you really need to know. As part of that initial primary airway exam, you want to observe their mouth and chest. Are there secretions in the mouth? Are there obvious foreign bodies? Are they stridorous? Okay, for some reason I wouldn't expect somebody 3 days post-op to suddenly develop stridor, but they're having a lot of secretion. That could potentially be the case. What's their respiratory rate and pattern? You don't have to auscultate to do that. I work in the ICU all the time, and many times I'll just go in and look at somebody's respiratory pattern. I can tell a lot by whether they're using accessory muscles, how fast they're breathing, what's the depth of their respiration. I can look at that and figure that out in 2 or 3 seconds, just watching. Their level of consciousness, Annie, are you okay? And then, of course, what we now call the fourth vital sign. Somebody in the back said vital signs. The fourth vital sign now is oxygen saturation from pulse oximetry. Okay. One of the things that I still see probably missed on the floor when evaluating patients when they come to the ICU is this one right here. Tachypnea should always be considered a very, very serious sign, and is one of the greatest signs of a predictor of somebody who's progressing toward critical illness. Never ignore tachypnea. What about circulation? Do I have to always take a blood pressure? Well, if the cup's right there, I can do that. But I can tell a lot about your circulation, the efficacy of the sufficiency of your circulation just by looking. Does the patient have pallor? Is the patient, I can do a distal capillary refill. What should your capillary refill be in your extremities, tip of your fingers? Less than 2 seconds, right? Anything 2 to 4 is under. Anything over 4 to 5 seconds is abnormally low. Are the extremities cool? Okay. Central and peripheral pulses. Generally, if you have a central pulse, you generally have a blood pressure of at least 60 systolic. Okay. You may lose a peripheral, okay? But if you have a central, you normally have a systolic of at least 60. I had a case in the ICU here a couple of years ago. I walked in for morning rounds, and one of the residents came up to me and said, well, we got this guy last night, overnight, and you know, our initial labs were fine, but you know, this morning his hemoglobin, the lab says 4. You know, the hemoglobin is 4. And he hasn't been having any obvious bleeding, but I don't believe it, so I'm going to send another one. And I said, well, fine, send the other one, show me the patient. I walk into the room with the patient. The patient's lying there, hardly responsive, can't answer my questions, and is pale as a sheet. I didn't need to repeat the lab. This person is in shock. All right. So I said, you fine, you go ahead and repeat the lab. We're going to start, you know, hanging fluids and blood right now. I don't know where the bleeding's coming from, but this patient's in shock. But again, it only took me 3 seconds to look at the patient and recognize that this was a situation. And that's what you need to do when you're approaching people. Okay, so we talked about the history, the focused history of the initial survey, the focused physical exam. What about chart review? How do you get more history as to what's going on with this patient? Well, when you're trying to make it a very initial assessment as far as this primary survey, you don't want to get their whole hospital chart and start flipping through it. But what you do want is any documentation of things that have happened in the most recent few hours. Okay. Now, when I trained, we used to keep written bedside notes either at the bottom of the bed or outside the room. I think now with electronic medical records, you rarely see that anymore. But the point is that you want to have quick access to these things that have occurred in the last few hours. Vital signs, and not just the most current vital signs, but have the vital signs been on a deteriorating trend over the last 3 or 4 hours. Okay? Fluid balance. Again, has this patient received 5 or 6 units of packed cells or 4 or 5 units of crystalloid in the last few hours? Because that could be very important information for this person. Have their oxygen requirements been going up? All right. Again, if somebody has not had any increase in oxygen requirements and suddenly is short of breath, that may change my thinking to something more like coronary disease or pulmonary embolism. But if they've slowly required increasing oxygen, I might be thinking more things like progressive pulmonary edema or pneumonia or so forth. Any medications that have been delivered. Again, I'm not interested in the 25 they're taking at home. I'm interested in the ones they've received very, very recently prior to this event. And then if you happen to be in a monitored setting, such as a step-down unit or ICU, you may have other things, such as the pulse oximeter, or someone may have a central line in which you would know their CVP or something like that. Okay, so here's the update on our person. Now we've pretty much made it almost through our primary survey. This, again, all this that I've talked about here for the last 15 minutes is happening within the first 2 or 3 minutes when you approach this person. So now we have a blood pressure of 100/40. They're tachycardic, they're tachypnic, they're febrile, their oxygen saturations are low, already on supplemental oxygen. They look anxious, confused. You auscultate rouse. Their bowel sounds are discrete with distended abdomen. Their extremities are warm. So they ask you which findings are most concerning. Well, again, I find this kind of a humorous question. I would phrase this as, which of these signs are not concerning? All right, because there are a lot of things here that should trigger your attention. As I said, blood pressures. Now, many people will say, oh, blood pressure is 140, that's okay. Well, you have to look at that in context. I mean, their pulse is 106, all right? So they're tachycardic as well as borderline hypertensive, and again, they're tachypnic. The SATs, of course, are concerning. To me, this is the one that gets my attention most. They appear sick. They appear anxious. You can pretty much tell when somebody is toxic, you know, when you go in and look at them. The bowel sounds and distended abdomen don't concern me as much because this person's 3 days post-op. All right, so they may have a normal post-operative illness. All right, that doesn't tell me a whole lot. But these things up here get my attention. So now, we're down to the 4th part of our initial survey. You've done the first 3. What investigations do you want to have on this person? What are you going to order? What are you going to tell the nurse or the ward clerk to order staff for you? All right, chest x-ray. I like that one. What else? Blood gas. Very good. You'll be surprised how many times I see people not get blood gases when they really need them. What? Anything else? CBC? Blood cultures. There's another thing I see under-ordered that nobody's mentioned yet? I'm sorry? You got it? How about an EKG? Did anybody say EKG? I didn't hear it. EKG. All right. So, biochemistry, CBC. I didn't hear anybody say particularly cultures, but again, at this point you should start formulating maybe the top 3 things that are in your mind that could be going on with this patient. Okay? So you might want blood cultures, urine cultures, x-rays, EKG. And then you have to have some assessment of whether this patient has an acidosis. Okay, whether it's respiratory or metabolic acidosis. Pick your poison. I go for arterial blood gases, but lactate is a reasonable surrogate, depending on the situation. I think the blood gas gives you a lot more information, assuming you know how to interpret it properly. But the point that I want to make, if you were taking this course, the whole FCCS course, and had your test, I can guarantee you this is a question on the examination afterwards, that you have to recognize that metabolic acidosis is one of your primary signs of somebody who's deteriorating into critical illness. So you've got to have some assessment of acid-base status. Okay, so you've ordered all those tests. They're going to take a little bit of time to come back. What are you going to do for this person? What interventions, based on what we know right now, are you going to do? Simple things. Remember, sometimes the simplest things will buy you time that is precious. How about oxygen? Yeah, okay. I like that one. Increase the oxygen, okay? All right, if she's lying flat, yes, she's going to ventilate, or her respiration is going to be most likely improved if you set her up, yes. Okay, fluids. Make sure she has intravenous access first, but yes, fluid. Now, I've seen people withhold fluids in people who are short of breath because they're afraid they're going to make them in heart failure. But remember, this person's borderline hypertensive, tachycardic. I will tell you as an intensivist for 20 years that you can rarely go wrong, at least challenging somebody with fluid to begin with. All right? If you're down the road and you're giving your 4th or 5th bolus of fluid and things aren't improving, then you may want to think about another approach. But you can hardly ever go wrong giving fluids to somebody who's declining from a hemodynamic standpoint. Yes? Well, what do you say? What is obviously fluid? Again, if I'm faced with somebody who is hypotensive right in front of me, tachycardic, and I don't know what's going on, and sepsis or something like that, or bleeding out is my differential in the top of my head, I'm still going to give that person fluid. Because I can give them fluid much more quickly than I can get a levofed or a dopamine drip put together. And again, you may be seeing this person on the floor or in the ED. You don't know where, maybe in the clinic. You can give fluid a lot easier. So again, I would still give fluid as my first intervention. Because you've got to support hemodynamics. That fluid that you give intravascularly will eventually force equilibrate into the extracellular spaces, but it may buy you necessary and precious time to support their hemodynamics until you can do something more definitive. Okay, so we've gone through the first 5. We've done a brief history, brief physical. We've done a chart review. We've ordered our basic labs that we're going to need, and we've made some very, very basic interventions at this point. Now, you have to determine, is this enough? Or does this patient have such limited reserve that they're still going to decline over the ensuing minutes to hours, and I have to do something else? And now you should be formulating in your mind some sort of differential, at least the top 3 to 5 things. So what do you think's going on with this lady at this point? Give me something that could be happening. This 54-year-old diabetic who's 3 days post-op and has shortness of breath. Okay, pulmonary embolism, that's one. What else? Myocardial infarction. Sepsis, okay. Anything else? Those are 3 big ones that I would think of. How about pneumonia, post-op pneumonia, from which she could or could not be septic, okay. How about just pneumonia? That's another one. Okay. Did I reverse that? Okay, no. So now after you've done these things, you're waiting for your labs to come back. Now we come into what we call our secondary survey. Okay? Now you're at a point where if you've started some things that will hopefully stabilize them, now you want more information. So what sort of things about your history might you now want to know? Now you have maybe perhaps a little luxury to go back and pull out the hospital chart and kind of see what has been going on with this patient. Do they have a history of chronic diseases? We talked about congestive heart failure and coronary artery disease before. Psychosocial issues. Are they a heavy smoker? Okay. Or do they imbibe a lot of alcohol? More extensive evaluation of their medications. Maybe now it's time to quickly peruse those 25 medicines they take at home. Allergies. Family history. What have I told you now that you find out by looking at the chart that this person has a history of factor V Leiden deficiency in their family? Now what might shoot to the top of my differential, or at least move up? Pulmonary embolism, okay, because this is a prothrombotic disorder. Ethical legal issues. Well, why would that be important? Well, what if this patient has got an advanced directive? I mean, you don't know what course this person is going to take over the next few hours. You're hoping that your intervention is going to pull them back a little bit. They may not want to be resuscitated should things go badly. They may not want to be intubated. So this is the time when you would get an idea about that. And then a quick systems review, quick review of systems. When I do a review of systems in a situation like this, I'm very, very quick. Cardiac disease, pulmonary disease, central nervous system history, seizures, for example, malignancy, diabetes, and we already know this person's diabetes. I try to hit those 5 things. That gives me a quick, brief overview. So as now as part of your secondary survey, as you've done these things, you've ordered these tests, you've started these very simple interventions, now we want to go back and do a more extensive evaluation as part of our secondary survey. So now, before we were looking at respiratory being just the airway open, are they breathing, do they have good circulation? Now I want to go back and actually use my stethoscope. I want to auscultate. Is this person having expiratory wheezing? Does this person have rows? Does this person have unequal breath sounds? That surgery resident was in 30 minutes ago, opening in the chest. Maybe now the fact that you pick up that you have unequal breath sounds, maybe you're thinking about pneumothorax. Cardiovascular, we know they have a pulse. We know that they have decent perfusion because we did that at the bedside when we first came in. Now I want to listen. Do they have a murmur? Do they have a gallop? Okay, is their rate irregular? Okay, this is where I'm going to now decide this. The abdominal and urinary examination. Well, we already know this person is distended and quiet abdomen. Again, that may not be such a surprise 3 days after surgery, but I want to look at the wound. Now, this person had a laparoscopic Foley, so the infection risk should be low, but you still want to look at that, okay, as part of this part of your examination. Central nervous system. I don't run to emergency situations with my reflex hammer, okay? But what I do when I'm assessing somebody who may be critically ill is I do a quick central nervous system examination. I can look at most people within seconds and get an idea of whether the 12 cranial nerve pairs are working properly or not, with just some simple things. Having them track, having them open their mouth, just simple things, assuming they're conscious, of course, which was part of our primary survey. I don't spend a lot of time with a good musculoskeletal exam unless there's been trauma that was suggested at the beginning. If the patient rolled out of bed 30 minutes earlier, then I might do a quick look at their extremities and make sure we don't have something that's obviously deformed. I don't spend a lot of time doing endocrine or hematologic, but I do look at their skin. Is there a rash or something that may be petechial, something like that? Are they diaphoretic, which could clue me into something else going on? As part of the chart review, as the secondary survey, now I'm going to do a more extensive review of their medical records. As I said before, now we might have a chance to pull out the chart and look at it. And probably one of my pet peeves that I talk to house staff about all the time is document, document, document. It's okay to document something in the chart that you're thinking and it turned out not to be the right thing. It's okay to do that, all right? But more errors are probably made from inappropriate or under-documentation than over-documentation. So take the chart out. Document what has happened. Document what your thought process is, your rationale. This is not only important from a medical legal standpoint, but it's also, remember, the medical record is a device to communicate with your colleagues. I can't tell you how many times I've seen somebody come off call at night, they were dealing with a situation, they haven't documented well, the day team comes on, and they have no idea what happened. You know, they may have got a one-line checkout or something, but without things written in the chart, how does that team that's now gone home communicate with their colleagues who are assuming the care for this person? So document, document, document. I cannot emphasize that enough. I've seen more mistakes over the years from omissions from documentation than I've seen people documenting things incorrectly. Okay, so back to our case. So this was our original examination on this person. Their blood pressure was 150 over 90. You got this from reviewing the records. Remember the short record review? You found out that hours before she had a low-grade temp, but her stats were 97 on room air. Her most recent white blood count had been 16,000. Now you're called to see her with the events that we've been talking about. She's hypotensive, tachycardic, tachypnic, febrile, lower sats. White count has jumped to 21,000. And this blood gas. Somebody give me a quick interpretation of the blood gas, not a complex acid-base description. What's going on here? Sorry? Yeah, acidemic. And this looks like a metabolic acidosis because she's hyperventilating and her CO2 is down. So we actually have a metabolic acidosis going on here. Now what? What's the next step? More fluids, I like it. Again, you're guided by the events that have happened up to this time. If you haven't ordered some things, you may want to go back and repeat. And there's nothing wrong, by the way, with repeating things. Your first APKG was difficult to interpret or whatever. The first chest x-ray was of poor quality or something's changing. Get another one. Get another blood gas. All right? Again, part of this course is to get you to intervene and do something and then reassess. Okay? That's the important thing. I see a lot of people, they do something and then they walk away or go see somebody else or whatever. But the point of this is every time you make an action, you have to reassess the efficacy of that action and then take the next step. So you want to refine your treatment. You always want to assess the response of your treatment. Continue providing organ support. So somebody said give more fluid. I like that. Okay, but what happens after that second or third liter if their blood pressure is not coming up? What do you might want to do? Yeah, right now one of he's thinking about taking the next step, which could be vasopressors, Levophed, dopamine, your choice. Determine the best site of care. If this person's in the ED, the things that you normally have to decide is this person stable enough to go home? Do they need to be admitted? If they need to be admitted, do they go to the floor? Do they go to the ICU? So you have to decide, depending on where you start from, where that patient can go. And then always call for advice and assistance from those some of your colleagues. So, the key points again to review, and then I'll take questions. Know how to identify patients who are at high risk, people who can deteriorate on you quickly. Know what the manifestations of critical illness are. Stabilize them first, sometimes with very, very, very simple interventions, and then later, think about your diagnoses. Create your differential in your head, and then focus your treatment. Obtain a detailed history, but do it in the primary sequence. Remember, during the primary survey, it's very simple, ABCs. Okay? The secondary survey, we get more into it. And then, as you do things, monitor your response to treatment, and take the next step. And the one thing they didn't put on this slide that I will re-emphasize is document, document, and document. And that takes us right up to just about 2 o'clock. I'm going to stop here, and I'll take questions from you guys, if there are any. Okay, I'll look forward to seeing you in the ICU. Thank you.